Hello, everybody. Welcome to our live USM only questions and answer series. Today we are joined by our wonderful Dr. Russell Hackburn. How are you doing today?
I'm good, it's Thursday, so I'm excited for the weekend.
Yeah, there it is.
Yeah, I'm
So,
always excited for the weekend.
I love the weekends. It's a great time. Okay, well, thank you so much for joining us here as we go through last week's question that we posted on our various social media platforms. So thank you to all those people who commented with their answers or any questions they had. We really appreciate it.
Yeah. So it's definitely good to see a lot of people out there definitely participating in this. I think it's a good exercise for, not just for those that are studying, but for those that are just curious to learn about different conditions. WebMD is nice, but nothing like some good old,
Some knowledge.
yeah. All right. So should we get started?
Yeah.
All right. So let's start with today's topic is about a bum knee. This is a counseling service here. My name is Dr. Russell Heckburn. I work alongside Dr. Aksa Chaudhry and Dr. Dewan Kinchlow. Those are our emails there, as well as our group email, usmle@mail.sjsm.org. Anytime anyone has questions or just want to bother us, feel free to reach out. We're here to answer questions. So definitely reach out when you can. And so taking the comic for a minute. So let it sit there for a second.
He's always here for the comics.
Yeah, I love the comics. I'm a cartoon guy. So, all right. Let's start with the question. So, it's a 65-year-old woman who comes to the clinic with complaints of progressively worsening right knee pain over the last 2 days. She states that her right knee feels warm to touch and is accompanied by redness and swelling. The patient has no other complaints. Physical exam is performed and findings from arthrocentesis of the affected joint is shown below. So what is the most likely diagnosis in this patient?
Soak it all in. What are you thinking when you see this?
I mean, the first of all, the arthrocentesis pretty much is the mnemonic right there, the buzz clue right there. So, as soon as I saw that, I had an idea what I was looking for. The symptoms would definitely be some form of arthritis. It's solely in the knee. She has no other complaints, so it's nothing really going on for too long. So I'd rule out C, D, E, and be left with A and B. So, help narrow it down a little bit.
Down for everybody. If you guys want to comment your answer choices below, I know he gave you a little hint.
Yeah.
So if you have any questions that you want us to touch on, please comment and let us know so we can be sure to answer those for you. But let's go to the next slide and give them the answer.
All right. So answer is pseudogout. So I highlighted the key things to take note of. So once again, it's progressively worsened. So let's go back. So I narrated between A and B because it's progressively worsening. It will be more pseudogout than gout. Gout is very acute. Also, there's no other complaints, so that's why I rule out reactive arthritis, which normally comes after an infection. Rheumatoid arthritis would be like there's a pattern in the pain, and it's a lot more joints. And septic arthritis will be a lot worse symptoms. Like it would progressively worse, and it would be like she won't be able to walk. She will be like sitting there like I can't even move. Doctor, come to me. So that's how I see it. But for this, the arthrocentesis shows this little weird rhomboid shape, which is pretty much characteristic of pseudogout. So if nothing else, the picture should have helped you guys. All right. So let's just kind of go over the wrong answers for a second. So just to repeat, gout more commonly in men. It's normally triggered by like meat and alcohol mostly, but can also be due to malignancies. Essentially, what happens in gout is there's a increased level of uric acid. So alcohol is made of something called purines, which breaks down to uric acid. Meat also has purines. Purines is seen like DNA, anything with living animals. So if you have a lot of that in your body or a lot of like cells in your body that's breaking down, then it can result in high uric acids, which leads to gout. Also malignancies, which is just cancers, which lose a lot of cells, hemolytic anemia, which is just red blood cells that are like being lysed or destroyed, so more cells being turned over. Leach-Needham syndrome is a genetic condition that can also lead to high levels of uric acid. So essentially uric acid. So once it's high, then you get an attack, which can be on your big toe most commonly, but it can also affect like other joints, but it's usually the big toe. So if a question ever says it was the big toe that was affected, we're more lead to gout than pseudogout. Reactive arthritis is said, as mentioned before, you know, after an infection. So it could be a GI infection, could be an STD infection, but usually there's an infection, and then after there's a joint pain that occurs later. It's usually like one joint at a time, or it might be the right knee and the left ankle. And there might be some systemic symptoms because they were sick. But so yeah, and that would lead me more to reactive arthritis if they had an infection before. There could be other associating conditions like conjunctivitis, which is just inflammation of the eye. Uveitis, also inflammation of the eye. Carditis is the heart. Aortic regurgitation is a valve issue of the heart. So yeah, but the thing about reactive arthritis versus septic arthritis is if you do like the arthrocentesis, which is just drawing fluid from the joint, there won't be any bacteria in it. It'll just be inflamed because the antibodies from the infection. So rheumatoid arthritis, I said there's a pattern to the pain. It's usually worse in the mornings, gets better as you move the joint more. You'll find it in middle age, more women than men, but mostly middle age adults. Uh, there's antibodies that help distinguish it as well. So you'll do like blood work, find like there's citrulline antibodies. There's rheumatoid factor, which is just another protein that we find. C-reactive protein and ESR, which are inflammatory factors, which raise when you have inflammation. That's there as well. If you do arthrocentesis, you'll find neutrophils, which are just like blood cells that go into like help with inflammation or any acute attack. And then septic arthritis, there's an infection going on. There's bacteria in the joint that's just going crazy, having a good time eating the cartilage, eating the sugar, eating everything. They're just going to town.
Hungry hippo.
That's what bacteria do. They come in, they're like, yay, food, go nuts. So when you do arthrocentesis, you'll find like purulent fluid, like kind of like pus. You do like a microscopic investigation, like on the slide. You'll find like a lot of cells in there. It could be bacteria, could be white blood cells, anything. There's a lot of cells. And if you stain it for bacteria, it's most likely going to be a positive gram stain. Most likely infective causes are like staph or strep are usually the ones that get in there because it's on the skin. And there's always like a point of like trauma or like some way that the bacteria got in or penetrated the skin. So those are the wrong options. So why was pseudogout right compared to the two or the four? Once again, gout. Pseudogout would affect the knee more than the great toe, and the arthrocentesis will show positively bifringent rhomboid crystals versus the gout, which shows the needles. Reactive arthritis, once again, pseudogout didn't have any infection. The patient had no other complaints. She had no other systemic symptoms or associated conditions. She just came in with the one knee issue. Rheumatoid arthritis, it's not multiple joints, it was one joint. There's no autoimmune process to it. And when you aspirate it, all they saw was just the little cell with a little rhomboid thing in it. No neutrophils were found. And septic arthritis, the fluid was clear. You saw the cells clearly. If it was septic arthritis, you would have said something about a gram stain or like some form of fever going on. So out of all the other options, if you're comparing it to, pseudogout was the one that fit. All right. So let's backtrack a bit, talk about arthritis. We'll get to the comics in a minute. I love Shrek, so I had to bring him on. But yeah, so arthritis is essentially just inflammation of a joint. There's different causes of arthritis. It could be degenerative, which is like osteoarthritis. That's essentially when there's a lot of friction or trauma or activity that's just wearing down the joint components, and then it's degenerative. There's inflammatory processes, which is normally mediated by autoimmune processes. So like rheumatoid arthritis, which is like antibodies towards something. Psoriatic arthritis, SLE, which is systemic lupus erythematosus. I think that's what it stands for. SLE, lupus. All those are autoimmune processes. So the body essentially is attacking components of the joint, which can then cause it to eventually deteriorate or degenerate over time. Metabolic processes like gout and pseudogout, there's something in the body biochemistry that's created too much of something that causes deposit of a component. So in gout was uric acid, pseudogout, it's calcium pyrophosphate. They deposit a joint, and then that in itself causes some form of inflammation. There's infective causes, as we talked about septic arthritis. Some bug gets in there, attacks it. And there's also traumatic causes like back pain or neck pain. Like you ever been like in an accident got like rear-ended, like your back pain? Yeah, that's traumatic arthritis. So, there's not much you can really be done for it, but then you just get painkillers for that. But so the symptoms of arthritis, they're very general. Pain, stiffness, decreased range of motion, and sometimes you get redness. Those are very non-specific signs to lead to a specific cause of arthritis, but it generally does describe an arthritic picture. So if someone comes in pain in a joint, stiffness, they can't really move it well, then you'll think, okay, well, you have some form of arthritis.
Makes sense.
Yeah, you should. Yes, you should definitely ask it. I'm not a Dunkin' Donuts, guys. I know. We'll go after.
Okay.
All right. Next slide. So now we're going to talk about pseudogout. The technical name for it now is calcium pyrophosphate deposition disease. The name itself describes the process that's occurring. So if you go and analyze those crystals, it's calcium pyrophosphate crystals. All right. So pseudogout or CPPD, which is calcium pyrophosphate deposition disease. So CPPD is one of the causes of chondrocalcinosis, which is essentially just calcification of the joint. And there's an acronym for the different causes called hogwash. We can go through some of them. H is for like hyperparathyroidism. It also stands for hypothyroidism. O is for ochronosis. It's hard to say that word. G is for gout, obviously. W is Wilson's disease, which is essentially just copper buildup in the body. A is for like arthritis, different causes of it. Damage to any form of tissue can lead to calcification of the tissue. So if you damage the joints, it can lead to calcification of the tissue itself. Amyloidosis, protein deposition, acromegaly as well. S is for pseudogout. It starts with a P. We're going to say S.
It sounds good. Yeah. So we're going to just call it that.
Yeah, well, it's like hogwash, and I don't think that's going to go far. And then H, the second H is for hemochromatosis, which is just increased level of iron in the body. All right, so essentially what happens in this condition, pseudogout, CPPD, calcium pyrophosphate, they meet, they create these complexes, and then they just sit in the joint. So if you're a patient that has high calcium levels or somehow creating a lot of pyrophosphate, then you're more likely to get this condition. So it's associated with hemochromatosis, hyperparathyroidism, and joint trauma. So, and these deposits, the calcium pyrophosphate deposits, they kind of trigger some inflammatory cascade. So that's why it becomes a problem. So there might be patients that have deposits and no symptoms, so it's not enough for your immune system to get like activated. But for others, yeah, the deposits themselves are causing inflammation, and it mostly affects like proximal joints, like the knee and the shoulder, the ones that are closer to like your center of your body, so shoulder, knee, hip, those are joints. Whereas gout was like the big toe, or like the hands, the fingers, digits. Yeah. All right. So the process of how this happens is there's different ways that it could happen all the first three options could be one of them, it could be all three. So chondrocytes, which are the cells inside the joint that create the cartilage, they essentially produce pyrophosphate, which is used to inhibit calcium phosphate mineralization. Calcium phosphate is the main component in bone. So it creates it so the bone can pretty much stay normal. No more deposits, no more, yeah, no more deposits, no more release. Just wants it to be calcium phosphate separate.
Okay.
But if you produce too much pyrophosphate, the calcium that's not binding to the phosphate can bind to the pyrophosphate, and then that then sits. So you have too high levels of the pyrophosphate meets the calcium joint. ANK gene mutation, the ANK gene creates a membrane that causes the pyrophosphate to go in and out of the cell. So if you have too much of those ANK gene expressed, you have too much of those channels, you have too much pyrophosphate being released out to the joint, calcium can meet. And also the ANK gene mutation can be hereditary, so you can be born with it, get it from your parents, or you can turn 30, 40, and one day, boom, oh my gosh, all of a sudden you have it. I don't know how to fix that one. Just things that happen. Next cause could be increased serum levels of calcium or other metabolic processes. So as I said, if calcium is too high, it will bind to the pyrophosphate. But hemochromatosis, it causes high levels of iron. Iron causes free radicals that stimulate or promote calcium forming complexes with the pyrophosphate, and then that leads to depositions. Hyperparathyroidism is a hormone that essentially is elevated when the parathyroid gland detects low levels of calcium. So it says, hey, I need more, goes out, somehow increases the level of calcium in your blood, too high, murder. All this, one of these three happens to you or to a patient, we don't know which one, but they essentially come with symptoms, or they have this deposition. The macrophages that go around circling the body, trying to remove anything that's abnormal, sees these deposits, says, hey, let's try and get rid of it. Grabs them, a bunch of them comes and starts grabbing them up. There's a little thing inside of them called an inflammasome. When the macrophage eats up the deposit, the inflammasome gets, wait, this is not normal. Need help. Sirens go off. Triggers everyone. Remember the last webinar? There was sirens. Triggers everyone, exactly. Everyone's like, yo, we need help. So it triggers caspase 1, which then eventually activates IL-1, interleukin number 1. That is what causes the inflammatory signs. So the swelling, the redness, the warmth, that's the IL-1. And then that's why we feel pain. That's why it hurts. That's why it's swelling, all that stuff. That's IL-1.
Sorry.
I know. It's the body trying to do its best, you know. We just gotta roll with the punches. All right, so just to compare and contrast, we have the healthy joint here. So you'll see the bone. This is the top. This would be the femur. This would be the tibia, and lining both ends, you see like this little smooth like layer right here. Hopefully you guys can see it. So that's the cartilage. That's where it is. There's also like meniscus here as well. But essentially, there's something lining both bones. So when they move, they're gliding against each other. That's why movement is so smooth. Your fingers and your hands, you don't hear groaning and creak. I mean, you shouldn't.
Shouldn't hear the creaking.
Hear groaning or creaking. So yeah, so it's all clear. There's the fluid in between synovial fluid. It's clear as well. But when you have the calcium pyrophosphate crystals, then you have that come into the joint, and it kind of acts like sand. So if you hope everyone has one time been to the beach and suffered from bringing sand home with you.
It stays everywhere.
Yeah, and it just gets everywhere, and then you know the sand's on you. Like you do anything and you feel the grit. Yeah, exactly, right? So that's what happens in the joint. The sand, the little rhomboid crystals, they go in like sand. When you're moving, it's going in, rubbing against it, making it less smooth, creating some damage, and that's how you get like joint damage later on. So when the patient comes in, how do we deal with the patient? We take a history, as we saw that patient, blah, 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 joint pain, started slowly, now it's getting bad, and what happened. Do the physical exam. We examine the joints in question. So this patient, they'll have a warm and tender knee, pain whenever they move the joint, passive or active, will most likely be pain in both. When you do lab work, you draw some blood, you ask them to give you a urine sample, fecal sample, whatever you want to do. You don't need to do all that. But whatever labs you get, it's mostly normal. You might find some high levels of calcium. Maybe in the patient that have some form of high like calcium producing condition, or some other condition going on. For medication, you want to give them something to help with the pain. There isn't anything that can really remove the joint, but what we can do is help with the symptoms. So we start off with NSAIDs, which is like naproxen or ibuprofen, and we give it to them so it decreases the pain. Over time, this is a relatively self-limited condition. It will go away on its own, but it'll be painful. So we give them painkillers to kind of help it out. You can also give colchicine if it's within 24 hours of the attack, like of when it first started, and that will help with reduce the symptoms. Anything beyond 24 hours, it's no better than NSAIDs, so we try to more stick to NSAIDs. Steroids is also an option if it's like one joint, you can give like an injection, or if it's a bunch of joints, you can give like oral medication for it. But we don't want to give anything IV. It's way too strong. And if we're going to give oral steroids, it's normally last line. After the NSAIDs don't work, colchicine isn't working, then we'll consider oral steroids. But if it's one joint, we can push that. All right. And how do we analyze it? I mentioned a few times before about arthrocentesis. What that is someone goes in with a little needle, like, well, like this. Yeah, like this, right? Like, give or take. And they go into the joint, they suck out some of that fluid, they put it on a slide, and they look. They analyze it with the polarized light to see if there's any crystals. They use electron or light microscopy to see if there's any cells or foreign material. They do gram stains to see if there's any like bacteria or things growing in it. And usually for these patients with pseudogout or CPPD, you'll find the calcium phosphate rhomboid crystals as we saw earlier. Remember the little here. Yeah, like this, right? If you guys don't remember that, remember me doing this. So remember, this is what pseudogout means. All right.
Who's the new Bob Ross?
Yeah. All right. And also you can do an X-ray as well to kind of see the extent of joint damage. MRI is better to see like soft tissue. So the cartilage is affected or the ligaments maybe, but X-ray will see essentially the joint space. All right. So I bring up here a very beautiful artistic picture of a knee joint. Like it's beautiful. I want to blow it up, put it on my wall, like
we'll frame it.
Yeah, like something. Like, do you not see the shaded lights? Like, you see here the knee, this is the patella right here, just looking at you, just like a cyclops, just bang. Well, the point of this I'm trying to illustrate is in the joint space, you can see right through it.
Yeah,
it's like you can see the 3D component of the tibia, which is the bottom here. So that's the top, this is the front, that's the back. Get it? And this here is the femur, the patella above it. Joint space is nice. The bone, the texture, it's fairly even. You don't see like heavy shaded. All right. So this one, now the quality is not the greatest. I have to blow it up a little bit. But what you can see is in the space, there's a white haze. It's a lot stronger than the one before. So that will be the calcium pyrophosphate deposit that you'll find there. Okay. So it may not be there for everyone. Some people that have this may not have any symptoms, but that's what the deposit will look like. Okay. All right. Yeah. And then when you do the astrocentesis on the left, I bring up what it will look like for gout. So you get crystals that look like needles. Mm. Parallel to light is yellow, perpendicular, it's blue. In CPPD, you have these rhomboid crystals. They'll, square thingies. Mm-hmm. As I said, looks like sand.
Looks like his little.
If you remember, all right. So that's what you look for when you see an aspirate of the joint. You put it against polarized light, you get one of these two. There's a crystal there. Gout, pseudogout. Oops. All right. And then prognosis. after we've dealt with the patient, what do we do with the patient? So if it happened once, it may happen again. And that's the thing with every form of arthritis. Once it's an attack, you're more likely to have a second attack. So what do we try to do? We try to rule out any underlying conditions. We want to reduce any likelihood of repeat episodes. High calcium, high pyrophosphate, is there previous damage? We're trying to fix those things. If we don't manage it, what could happen is it could be wear and tear of the cartilage. There could be bone cysts or spurs. So essentially the bone gets damaged and the bone is rubbing the space, but it gets damaged. The bone then tries to heal itself, so it heals abnormally. Bone isn't supposed to like really heal or recover, so it just makes a patch. So if you rub off like a little part of it, it might grow like a whole hand. So yeah, so bone spurs or bone cysts can occur. And also in the joint space will get narrowed. So the reason why when you look at the x-ray, you see that space in between, the x-ray is going right through the cartilage. So if the cartilage is wearing down, the space is wearing down. So the narrower the space, the less cartilage there is. And then if this bone to bone rubbing against each other, there'll be fibrosis, which we call sclerosis. All right, and what we can use is colchicine to help reduce future episodes. So colchicine is good in a very acute presentation, or if the patient is prone to many episodes, it can reduce the amount of episodes they have. Doesn't necessarily cure it, but it does reduce it. And that's it for CPPD. I know it's a little bit of a lot of knowledge, a lot of information.
A lot going on.
Yeah.
But it was good.
Yeah.
A lot of fun pictures along the way.
Yeah, that's what I try to do, try to make it fun, I think I do need some oil for my knees. Not cost, there's no CPPD, but I think I'm just an old man getting arthritis. Some regular arthritis. So
Oh, no.
yeah.
That's not good.
Yeah. Yeah, I hope this was clear, helped a lot of people out. I try my best to kind of hit all the points that A will be tested on, and B, what you just need to know for your own knowledge and going forward. If you do feel knee pain coming on, you don't have to immediately think it's costochondritis. Or it could be CPPD, or it's osteoarthritis, or even septic arthritis. It could just be regular wear and tear, probably walk too much. But definitely good to know if you feel the knee pain getting worse, definitely get it checked out. It won't kill you, but it might make your life more difficult than work.
The smile at the end.
Yeah.
Well, thank you everybody so much for joining us today. We really appreciate you guys tuning in. If you do have any questions or would like us to retouch something, or just kind of focus on just an area that you have a question on, please be sure to comment on the post, or just direct message us, and we will be sure to answer that in a timely fashion. So thank you so much for joining us today.
Oh, thank you for having me.
We're doing it
Yes.
in person now, that all the Zoom sessions, which is great. So we will see you next Thursday on our social media pages for a new question, and then that following Thursday with a new live video. So thank you all so much for joining us, and we'll see you again soon.